বর্ধমান মেডিকেল কলেজের পিজিটি, ও অনেক অ্যাওয়ার্ড পেয়েছে, ও খুব ভালো বলে, তাই জন্য আমরা ওকে রিকোয়েস্ট করলাম যে এখানেতে এটা আমাদের বর্ধমানে একবারও করেছিল, আমরা বললাম যে এটা কলকাতায় বলে একটু আমাদের মুখ উজ্জ্বল করো, তাই জন্য ওকে আমরা request করে দিয়েছি। ঠিক আছে, থ্যাংক ইউ।
বৃষ্টি পরে টাপুর টুপুর, নদে এলো বান, শিব ঠাকুরের বিয়ে হলো, তিন কন্যা দান। Welcome monsoon, as the rain quenches the thirst of the hungry mother earth. The small boy goes out of his home to play in the field, and he looks up at the sky and sees this wonderful scene of rainbow, the enigma of colors. He is dumbfounded. But truly, in our daily life, these colors do exist. These colors exist in different forms. They are intertwined, intertwined. And from that, the concept of physics has come, where the modern psychiatry, about 203 years old, has its own diagnosis with diseases, disorders, syndromes, have all intertwined together to form one common spectrum. A very good evening, respected chairperson sir, esteemed guests, my colleagues, and this august gathering. At the outset, I would like to thank Dr. Debashish Kunar and Professor Uday Choudhury sir to give me the privilege to present before you a humble presentation on obsessive compulsive spectrum disorder, and with a special reference to the pathophysiology of OCD. I take this opportunity to present before you this small journey. It is in fact a journey of decades, which I have to complete within 30 minutes. The outline of presentation gives a synopsis of what we will talk about and what we will see through these slides. We will try to dig into the well and find out what disorders or diseases do classify for the obsessive compulsive spectrum and what do not. What are the reasons? What are the reasons for objection? It is a controversial topic, it is a debatable topic, yet it is a topic which no one can overlook. It was in the year 1998 that Professor Eric Hollander, currently working in the Albert Einstein Institute, Department of Impulsive Disorders, had proposed that a number of disorders to be included as obsessive compulsive spectrum disorder on the observation that OCD and OCSD share many common features. These features are shared features. These are similar clinical symptoms of repetitive behavior and thought, similar age of onset, chronic clinical course, comorbidity of similar symptoms, and insight ranging from full to poor. He observed the similarities in the brain circuits and the neurotransmitters involved, the similar demographic and family history, response to the same anti-obsessional drugs and not other anti-anxiety drugs or antidepressants. So Hollander divided OCD into the following categories. Category 1 is preoccupation with bodily symptoms. Category 2 is the impulsive disorders or the impulse control disorders. Category 3 is the neurological disorders. So what he said was that OCD is the primary diagnosis. It is intermixed with neurological disorder. In the neurological disorder, we have the Tourette syndrome, the Sydenham's chorea, torticollis, autism. Then comes preoccupation with bodily sensation, body dysmorphic disorder, depersonalization disorder, anorexia nervosa, hypochondriasis. And the last, impulse control disorders or the impulsive disorders, in which comes sexual compulsion, trichotillomania, pathological gambling, kleptomania, self-injurious behavior. So what Hollander and his colleagues did at the Albert Einstein Institute was very fine. They tried to establish the reasons for obsessive compulsive spectrum disorders, because otherwise what is the need? When all of these exist as separate entities in the DSM or ICD, what is the need for putting them under one umbrella or under one common spectrum? He said it helps screening, it enhances treatment, it gives access to insurance, which is a major issue in the Western world. It influences research funding agencies. It enhances endophenotyping effort. The disadvantages are anxiety is a target for CBT. So most of the patients diagnosed with anxiety disorders will not come to psychiatrists but will go to the psychologists. There will be fragmentation of anxiety clinics and there might be decreased use of anti-anxiety drugs for OCD. The references are given. So Hollander and his colleagues tried to put them into all the categories, obsessions and or compulsions, and they saw the associations and put them into dimensions. On what dimensions can they be put? Because in 1950s, 60s or 70s, there was no difference between the concept of impulse and compulsion. That is, impulsion and compulsion, there existed no difference. But today, they tried to put them into these categories like insight, impulsivity, tics, motor-sensory, reward sensitivity, attention, mood, anxiety, and social behavior. So what they did a continuum or a dimension concept. In the dimension on one end was the compulsivity and on the other was the impulsivity. The impulsivity was more towards bipolarity, and under this the disorders were bipolar disorder and impulse control disorder. While lying on the other end of compulsivity, there was OCD and major depression. And in between compulsivity and impulsivity, the midline state were the mixed compulsive, impulsive or affective states. So how to do this work? This was a major work. So they started endophenotyping and they started this concept of grid, GRID, that is endophenotyping grid. So they started taking history of patients with different symptoms and putting them under phenomenology, comorbidity, course of illness, family history, genetic factors, brain circuitry, so on, in this way. Next.
Future engineering important তুমি যেটা এগুলো একটু বলে দাও কারণ কি ফিউচার ক্লাসিফিকেশন এগুলো সব ইম্পর্টেন্ট হবে এখন হয়তো ইমিউন ফাংশন আচ্ছা বল
So read one. So the cross-cutting issues, they took the following disorders: obsessive compulsive disorder, personality disorder, hoarding disorder, Tourette syndrome, Sydenham's and Pandas as one, trichotillomania, and body dysmorphic disorder. They started putting them into phenomenological classification, the comorbidities associated with them, the course of the illness, presence of family history of similar or other type of disorders, the genetic factors if it can be located, the neural circuitry involved, the cross-species findings, whether they are present in other species or not, animal models in the research, immune functioning in these patients, pharmacologic dissection, that which patient responds to which group of drugs, interventional treatment, that is whether they treated better by CBT, BT, interpersonal therapy, or any other form of surgery, and cross-national ethnic issues, which is very, very important, though I was going away from this slide, that whether this endophenotyping grid is valid not only for the US, but also for other countries, and it is the same. In the grid 2, again, it is a continuation of the grid 1, they took these disorders: autism, eating disorders, Huntington's chorea and Parkinson's disease, schizo-obsessive disorder, impulse control disorders not elsewhere specified, and addiction. The difference between impulse control disorders and impulse control disorders not otherwise specified is that not otherwise specified category includes internet addiction, sexual addiction, which are now coming in the CTP 10th edition. So what they made was again a dimensional approach with impulsivity on one end and risk aversive behavior on another end. In the risk aversive behavior, they found OCD, body dysmorphic disorder, anorexia nervosa, depersonalization, hypochondriasis, so on. In the middle they found binge eating, compulsive buying. While at the extreme impulsive end they found antisocial personality disorder, borderline personality disorder, sexual compulsion, pathological gambling, and kleptomania. So they started their research. So what came out of this research was a dimensional approach. A dimensional approach to all these disorders. Like, on one end it was compulsive, on the other end it was impulsive. The compulsive, just as we go down the ladder, we are going down the ladder, we will see what are the compulsive on the upper end, and on the lower end there is impulsive. Body dysmorphic disorder, anorexia nervosa, depersonalization disorder, Tourette syndrome, trichotillomania, pathological gambling, sexual compulsion, impulsive personality disorder. Though sexual compulsion is a compulsive disorder, it is more towards the impulsive end. So, what is compulsivity and what is impulsivity? If this is the question that arises in the mind, because they are doing it on this basis. So they found out that compulsivity has a unipolarity in nature, while impulsivity is more towards the bipolar spectrum end. In compulsivity, there is harm avoidant behavior, there is presence of insight, there is resistance to impulses and behavior, and there is absence of pleasure. If we take the case of OCD, the compulsions cause significant distress to the patient, and there is no pleasure. While in impulsive disorders, that is impulse control disorders, there is a pleasurable feeling, no matter how much remorse, guilt the person have after stealing an object from a shop. The nature of the act gives a pleasurable feeling. The act of stealing for kleptomaniacs gives a feeling of pleasure. Based on insight, Hollander again classified it that the OCSD was towards without insight, while the OCD was moving towards insight. The above classification was modified by Akiskal and Insel into two parts: obsessive compulsive neurosis and obsessive compulsive psychosis. They say, obsessive compulsive neurosis and obsessive compulsive psychosis. The obsessive compulsive spectrum disorder was more towards the obsessive compulsive psychosis part, whereas the OCD is towards the obsessive compulsive neurosis part. We all know what is an obsessive compulsive disorder according to the DSM-4. An obsession is defined as an idea, impulse or image which intrudes into the conscious awareness repeatedly, recognized as one's own idea but is ego alien. Insight is present. The patient tries to resist it, against it, but is unable to. The failure to resistance leads to marked distress. And this is what they say: I am not obsessive, I am not obsessive, I am not obsessive. A compulsion is defined as a form of behavior which usually follows an obsession. The main aim is preventing the anxiety or distress arising out of an obsession. The behavior is not realistic and is irrational or excessive. Insight is present, so the patient realizes the irrationality of compulsion. The behavior is performed with a sense of subjective compulsion. Coming to the OCD cycle, actually we will be dealing with many disorders. I will be telling them about them in very brief, and we will ultimately come to the goal that where we stand regarding obsessive compulsive spectrum disorders. What do we know? Where do we go? That will be our aim. In the OCD cycle, there is an obsession. The obsession leads to marked anxiety. The marked anxiety causes compulsion. To relieve the anxiety, there is ultimate relief. Ultimately, again, the obsession arises. So this is the vicious circle in which OCD propagates. If we come to the neurobiology or the pathogenesis or the pathophysiology of OCD, serotonin has been the most important culprit in causation of OCD. But it can cause, theories have found that only 50% of OCD neurobiology can be explained by serotonin alone. Serotonin hypothesis is the most accepted hypothesis. It is supported by the fact that clomipramine and other SSRIs are effective in OCD. Positive response to SSRIs with high CSF5 HIAA, exacerbation of OC symptoms with 5-HT agonists, that is a challenge test. However, this is the new finding by Eric Hollander. SSRI's effectivity in OCD does not mean that there is only serotonin dysfunction, because SSRI acts via modulation of 5-HT. SSRI downregulates the 5-HT1D autoreceptors in orbitofrontal cortex. Increased serotonin transmission in OFC is responsible for the improvement we see with SSRIs. And that is why it takes long and a greater dose to achieve this. Now the serotonin subtypes are there, acting presynaptically and postsynaptically on the receptors. The receptors involved are dopamine and OCD. Relationship has been found between OCD symptoms and severe neurological disorders associated with dysfunction of dopamine in the basal ganglia. The basal ganglia has always been the place where we localize OCD. 40 to 90% of today patients also have OCD. Increased activity of platelet enzymes. Different pathways of dopamine is involved in OCD spectrum disorders. How? This is the mesolimbic dopamine pathway. The mesolimbic dopamine pathway is responsible for the eating disorders, the somatization disorder, hypochondriasis. It is also responsible for compulsive sexual behavior, compulsive buying, and pathological gambling. Dopamine and the OCD spectrum. The mesocortical pathway. Dysfunction in OCD. The mesocortical pathway is dysfunctional in OCD. That results in the cognitive impairment, attentional problems, affective flattening, poverty of speech, and psychomotor retardation. The tuberoinfundibular pathway, dysfunction in OCD or OC spectrum disorders, causes increased prolactin level, which we see in patients of impulse control disorders. Amphetamine and cocaine both increase OC symptoms. There is increase in dopamine binding in basal ganglia. However, decrease in OC symptoms is seen when a SRI or SSRI is combined with a D2 blocker. Higher synaptic concentration of dopamine in basal ganglia of OCD patients have been reported. Now, is only serotonin and dopamine the main neurotransmitters involved in the causation of OCD? Can we go beyond that? Let us see. Noradrenaline. The role of noradrenaline has been relatively underestimated. Based on the positive response of OCD patients with clonidine, we see that many patients of OCD have responded well to clonidine. Neuropeptides have now been implicated. There is increased level of oxytocin and vasopressin. Another neuropeptide, somatostatin. The opioid peptides, tramadol. How we come to this conclusion? We come to the conclusion by the pharmacotherapy results. Tramadol is useful in refractory OCD patients. Now, after all talking about all this neurochemistry, neurobiology and neuroethology, Hollander said that ultimately we have to come to a conclusion regarding OCD and this tic disorder, Tourette syndrome, Huntington's. So what they did, they divided the obsessive compulsive spectrum into two parts. What are the two parts? One is the body dysmorphic disorder plus non-tic OCD. Body dysmorphic disorder plus non-tic OCD is one endophenotype. Another endophenotype is Tourette syndrome plus tic dependent OCD. In this part, the non-tic OCD, it is the orbitofrontal dysfunction. And the treatment is SSRI. We all know and we have found good results. Whereas when it is with Tourette syndrome or tic dependent tics associated with OCD, the pathology is in the striatum and the treatment is antipsychotic, be it haloperidol or risperidone. Neuroendocrine theories. I would have skipped this slide except for the fact that one major proponent of OCD in India, Professor Sumant Khanna, has done enormous work on this, the neuroendocrine theories. Initially, it was found in Western literature that the HPA axis dysfunction, that is increased ACTH, leads to increased symptoms in OCD. Later, hyperresponsivity of HPA axis leads to OCD was given by Professor Khanna. Now, at present, with the literature, we find that HPA axis dysfunction is non-central to the pathophysiology of OCD. Whatever might be the status, it is non-central to the pathophysiology of OCD. Neuroimmunology. There has been a lot of studies regarding this. Exciting research in neuroimmunology has been done over the past 2 decades. Relationship has been found between Sydenham scoria and streptococcal infection. Sydenham scoria had a high prevalence of OCD by Swedo et al. In 1997. Autoimmune response against basal ganglia. That is, this group A beta hemolytic streptococcus produces an antibody that is directed against the basal ganglia, and that attacks the basal ganglia and causes reduction in the volume of basal ganglia. So there is basal ganglia volume reduction. However, there is good response with immunotherapy. This is the basis. PANDAS, pediatric autoimmune neuropsychiatric disorders associated with streptococcal infection. Just highlighting the main points. Presence of OCD or tics is must. Pre-pubertal, out 1, 2, 3, 4, 5, 6, 7. Out of these 7 criteria, 4 has to be met for PANDAS. Any 4 of them have to be present to diagnose a PANDAS. Presence of OCD or tics, pre-pubertal onset, episodic course of onset, associated with group A beta hemolytic streptococcal infection, associated with neurological abnormality. PANDAS may be autosomal recessive inheritance. B lymphocyte antigen D817, which is a genetic marker, if it can be shown. Neuroimmunology continued. Thus, the same points that D817 expression with childhood onset OCD and Tourette syndrome has been found by Murphy. Increased CSF cytokine 1 has been found in OCD cases. This is a picture of streptococcal infection within a cell. Coming to neurogenetics. Genetic factors have a significant role in OCD. Twin studies, family studies, and adoption studies have been corroborated. Candidate genes that have been proposed are 5-HT2A, 2C, DRD2, DRD3, 4, so on, and the COMT locus. Recent study shows 5-HT1B, 1D gene to be important and has been associated with about 70% cases of OCD and OCSD. Linkage analysis shows 9p24, that is the chromosome 9, petit, that is the small arm, and 24 is the band. Glutamate transporter gene SLC1A1 has also been possibly indicated. Now, what is the risk for developing OCD? We know that OCD, when it is getting transmitted, it gets transmitted in the form of a familial nature. All these studies have found that it is a genetic disease, it gets transmitted in the familial form, except for PANDAS, which is a streptococcal infection. So what happens? It is either, there are 3 forms. If we go back, one is the non-tick related OCD. One is no familial relationship, that is those with PANDAS and Sydenham scoria. And one is the early age of onset with Tourette syndrome. So these are the 3 ways in which it gets penetrance within the familial studies. Neuroethology. Do only men or mammals or human beings suffer from OCD? Is it so? Let us see. OCD-like symptoms are common in animals, mostly in dogs and cats. Most studied one is canine acral lip dermatitis. Acral lip dermatitis responds to clomipramine. This study was done by Rappaport et al. In 1992, a famous study. Neuroimaging.
Acral মানে কি acral? Acral কথাটা কি?
অ্যাক্রাল মানে গায়ে যে লিক করছে,
বুঝলাম।
এই যে এইখানে যে কুকুরটা চাটছে যে অ্যাক্রাল পার্ট অফ দি বডি, ফেস অ্যান্ড এই পার্ট অ্যাক্রাল লিক, এবং সেখানে সে ডার্মাটাইটিস হচ্ছে। For the sake of simplicity, we have incorporated neuroimaging within neuroanatomy. OCD has been associated with movement disorders and neurological conditions. This was first cited by Westphal in the year 1878. Westphal-Edinger nucleus we all know. The caudate nucleus, the putamen, the substantia nigra, and the entire thalamus has always been the putative part that has to play a role in OCD. Neuropathology, just going through the imaging studies, the structural studies shows that there is increase or decrease in the size of orbitofrontal cortex, striatum or thalamus, increased activity in the caudate. This is the most important, increased activity in caudate, orbitofrontal cortex and cingulate cortex. There is dysfunction in the cortical basal ganglia loop, and that is the result for Huntington's, Tourette's, maybe Parkinson's, maybe Sydenham's, Korean also exhibit OCD. So they have done a lot of studies. The study shows that reduced left orbitofrontal cortex in OCD patient correlates with the severity of symptoms. These studies are there. Reduced caudate volume has been well documented in textbooks. Regarding the prefrontal cortex, we will talk about them. The corticostriato-thalamocortical loops, the CSTC loops, if we just oversimplify, this is just an oversimplification of such a difficult pathway. There is one part of the cortex, the orbitofrontal cortex. The most important function of orbitofrontal cortex is response inhibition, emotion, personality, and social behavior. We have the dorsolateral cortex, whose function is executive planning, attention, and working memory, and the anterior cingulate cortex, whose function is initiative and motivation. Now, we will not go into the very difficult circuitry. We will see them in a very simple way, just one by one. Let us come to the dorsolateral prefrontal cortex. So this is a cortex. This is dorsal caudate. That means the basal ganglia or the striatum. This is the globus pallidus internus and the thalamus. So this is cortico-striato-thalamo-cortical loop. Am I able to give the correct impression? So the work of dorsolateral prefrontal cortex is storing and integrating information, focusing attention, planning, organizing goal-directed behavior. Any dysfunction in this loop, cortico-striato-thalamo-cortical loop, causes motor optic dysfunction. Coming to the second, the main loop for OCD, orbitofrontal cortex, cortico-striato. Here it is ventral cortex. GPI is the globus pallidus internus, thalamo, cortical loop. Context-related functions, decision making based on effective information processing. Ultimately, dysfunction in this group leads to obsession and compulsions. Coming to the third group, the anterior cingulate gyrus projects two ways, to the nucleus accumbens shell and to the amygdala. Let us take this one first. From the cortex, anterior cingulate cortex, nucleus accumbens, cortico-striato-thalamo-cortical loop. Dysfunction in this causes addiction, because this is actually the reward path. This is in short the reward path. ACC projects to amygdala, midbrain, thalamus, and back. This has not come in the slide. Thalamocortical loop. This dysfunction causes anxiety. Now, if we see the OC spectrum disorders, all of them are present. The motoric function, repetitive hand washing, flinging of arms in Sydenham, Korea, obsession compulsions as we see in pure OCD, addiction as in pathological gambling, in sexual compulsion, kleptomania, and anxiety as in body dysmorphic disorder, hypochondriasis. So all these together are dysfunction, leading to this entire spectrum. This is part by part breaking down of the spectrum. So what happens in the basal ganglia is very simple. The CT scan reveals increased ventricular to brain ratio. Functional study shows increased brain activity of the basal ganglia in both rest and exposure to stimuli. So that means the basal ganglia is always activated in OCD patients. Not only in OCD patients, but also in patients with movement disorders. Basal ganglia is always very much activated. So what it ultimately leads to is that there is two parts. One is the caudate nucleus and one is the putamen. If there is a dysfunction in the caudate, it will lead to OCD. If there is a dysfunction in the putamen, it will lead to Tourette syndrome. So this is for the simplification of the corticostriato-thalamocortical loop. Corticostriato-thalamocortical loop. Negative, positive feedbacks have been given. Important structures: thalamus, amygdala, hippocampus, substantia nigra all play a part. Now, coming to the real part, as Professor Stahl was given had a lecture, and I had the opportunity to see the video on YouTube. So this is very important, that the frontal cortex, this is the cortico-striato-thalamocortical loop. If we just go through this, the frontal cortex projects on the striatum. Striatum projects to the basal ganglia, that is the GPI and the GPE, that is the globus pallidus internus and externus. It goes to the subthalamic nucleus and then to the thalamus. And again this feedback continues. There is only one negative feedback here, which is called the direct pathway, and this one is called the indirect pathway. In short, the direct pathway and the indirect pathway are in continuous harmony. The direct pathway allows you for extra movement. It allows you to wash your hands, it allows stick movements, it allows vocal movements. The indirect pathway says no, you don't do these movements. It stops, it is inhibitory in nature. So what happens in OCD is that the direct pathway is getting a more preponderance than the indirect pathway. This indirect pathway is actually being damaged. The indirect pathway, which was inhibitory to the movement, is stopped, and as a result there is OCD. So we see that in this picture, this lady is washing her hands. Obsessions were all right, but the compulsive motor acts was controlled by the indirect pathway. The indirect pathway is now cut off. So obsessive compulsive disorder results. At rest, it is found there is increased activity of the orbitofrontal cortex, increased activity of the cingulate. So these are just findings of MRI, fMRI and SPECT. Overactivity of the prefrontal basal ganglia loops, we can just overlook them. Increased activity in the thalamus at rest, showing that the thalamus is overactive. Now, is only basal ganglia the part that is involved in OCD, or are some more parts of the brain really involved? The frontal lobe is supposed to be involved in OCD. Frontal lobe activation in OCD has been found consistently. The temporal lobe dysfunction in OCD. How do we support? Anticonvulsants are used in resistant OCD and have yielded good results. This proves that there are a lot of studies, this is just the highlight, that temporal lobe may be involved. Cingulate lobe, responsible for repetitive behavior, is involved in OCD, and this is the site for psychosurgery. Under research is the role of hippocampus in OCD. Still, we do not have any evidence or data. Now, coming to the behavioral theory, since we have gone for the anatomical neuroimaging, the oversimplistic, a neutral stimuli gets paired with a noxious, anxious, anxiety-producing events. There is a fear or anxiety which leads to obsession, which is a conditioned stimuli. The obsession produces a great anxiety or discomfort. This discomfort has to be overcome with a compulsion, which becomes a learned behavior, and ultimately this cycle continues. We are age-old theory of psychodynamic theory of Sigmund Freud, whether it is arrested in the anal sadistic phase, fixation in development, regression. If fixation occurs in the anal sadistic phase, reaction formation is there, obsessional personality trait. But if there is regression, reinforcement of the anal aggressive impulses, new defense mechanisms like isolation of affect, undoing and displacement develop, and OCD develops. This is the Freudian concept. Symptom patterns, we all know that contamination, pathological doubt, intrusive thoughts, symmetry, other religious obsessions and compulsions are there. The comorbid disorders, the most important is major depressive disorder. Treatment, the senior psychiatrist with more than 3 decades of experience know more than me and my seminar, so it is just a overlook. The newer treatment approaches are RTMS, deep brain stimulation, ECT, psychosurgery, cingulotomy, subchoroid tractotomy, capsulotomy. Now, impulse control disorders. Impulse control disorders, there are 6 different conditions in impulse control disorders, namely intermittent explosive disorder, kleptomania, pyromania, pathological gambling, trichotillomania, and impulse control disorders not otherwise specified. Now, we will deal with the basis why impulse control disorders is a part of obsessive compulsive spectrum disorder. Impulsive disorders such as pathological gambling and sexual disorders have been posited to lie on an impulsive end, as we have already previously seen on the impulsive end, that is this part, of the compulsive impulsive spectrum, Bards and Hollander, 2006. Although these disorders are characterized by impulsive, there may be a compulsive element to them. In fact, they function to reduce anxiety and are characterized by repetitive thoughts and behaviors by Hollander and Baum. That was an old study in 1995. Coming to, we are leaving intermittent explosive disorder because this has not been put under the part of OCS. There is, supporting data is not very much. Kleptomania. We all know what is kleptomania. There is recurrent failure to resist impulses to steal objects, not needed for personal use or for monetary value. We know what they do. The stealing is not planned and does not involve others. The object stolen is not the goal. The act of stealing is the goal. The epidemiology, male to female, we know female shoplifters are more common than male. The major comorbidities are major affective illness, mainly depression, anxiety disorder, other impulse control disorders, eating disorders, substance use disorder, and alcoholism. Course and prognosis is there. Psychotherapy, behavior therapy, pharmacotherapy. Very difficult to treat kleptomania. Pharmacotherapy, fluoxetine, fluvoxamine, trazodone, lithium, valproate, naltrexone, and ECT have been approved. Now, this is the image of flames. According to the Freudian concept, this represents the phallus. In the child, the phallus, what is represented in the mind, in the adult, it is the shape of the flame. We come to pyromania. It is recurrent, deliberate, and purposeful setting of fires. It is associated with tension or affective arousal before setting fire. There is fascination with the objects of fire. There is pleasure, gratification, or relief when setting fire or when witnessing or participating in the act. It is different. Pyromania is a mania, though it falls under impulse control disorders. It is different from arson, where arson is for revenge. Here there is no revenge. It is a pleasurable feeling. The prevalence, no data is available. Comorbidity, affective disorders, enuresis, personality disorders, mainly borderline personality disorders, attention deficit, and learning disabilities. Course and prognosis, it begins in the childhood. We come to the treatment. Behavioral approach, supervision of parents to prevent repeated episodes of setting fire, family therapy, intensive intervention to prevent and not for punishment.